my name is Shayla Nolan, and I will be presenting Intermittent Explosive Disorder. The DSM diagnostic criteria for IED is recurrent behavioral outbursts representing a failure to control aggressive impulses as manifested by either of the following: verbal aggression, such as temper tantrums and tirades, or physical aggression towards property, animals, or other individuals, occurring twice weekly on average for a period of 3 months. The physical aggression does not result in damage or destruction of property and does not result in physical injury to animals or other individuals. The second part of Criterion A is that 3 behavioral outbursts involving damage or destruction of property and/or physical assault involving physical injury against animals or other individuals occurring within a 12-month period. The impulsive or anger-based aggressive outbursts have a rapid onset and typically only last for 30 minutes or less. Criterion B is the magnitude of aggressiveness expressed during their current outbursts is grossly out of proportion to the provocation or to any precipitating psychosocial stressors. Criterion C is the recurrent aggressive outbursts are not premeditated. For example, they are impulsive and/or anger-based, and are not committed to achieve some tangible objective, such as to gain money, power, or intimidation. Criterion D is the recurrent aggressive outbursts cause either marked distress in the individual or impairment in occupational or interpersonal functioning, or are associated with financial or legal consequences. The chronological age for IED is at least 6 years older or the equivalent developmental level of a 6-year-old. Criterion F is the recurrent aggressive outbursts are not better explained by another mental disorder and are not attributable to another medical condition or to the physiological effects of a substance. For children ages 6 to 18 years old, aggressive behavior that occurs as part of an adjustment disorder should not be considered for this diagnosis. Note that this diagnosis can be made in the addition to the diagnosis of ADHD conduct disorder or ODD or autism spectrum disorder when recurrent impulsive aggressive outbursts are in excess to those usually seen in these disorders and warrant independent clinical attention. The course and prevalence of IED is about 2.7% in the United States. These prevalence rates come from the DSM-5, however, studies suggest that these rates might actually be higher. IED is also more prevalent in younger individuals and individuals with a high school education or less. Onset is most common in childhood or adolescence and very rarely begins after the age of 40. The functional consequences of IED include the loss of friends or relatives, occupational problems, and financial or legal issues due to these aggressive outbursts. This disorder appears to follow a chronic and persistent course over many years. For the prognosis, IED is episodic with recurrent periods of impulsive aggressive outbursts. IED has a high comorbidity rate with other disorders such as depressive disorders, anxiety disorders, and substance use disorders. The risk factors of IED include environmental risk factors, such as individuals with a history of physical and emotional trauma in the first 20 years of their lives have an increased risk of developing IED, and there are also genetic and physiological risk factors, such as first-degree relatives of individuals with IED are at a higher risk of developing the disorder themselves. Twin studies have demonstrated a substantial genetic influence for impulsive aggression, which shows that there is a high genetic influence of IED. The cultural considerations for IED include that the United States has higher prevalence rates as compared to certain Asian and Middle Eastern countries. Certain countries such as Romania and Nigeria are seen to have lower rates as compared with the US. Significantly lower rates as compared with the US. This suggests that cultural factors are related. Some studies have also found a greater prevalence rate of IED in males as compared to females, with a ratio of 1.4 to 2.3 as compared with females. However, there are other studies that have found no gender differences, so there is clearly more research that is needed, both in gender and cultural considerations of this. During my literature review of IED, I found that intermittent explosive disorder first appeared in the DSM-3 in 1980. However, passive-aggressive personality aggressive type was in the DSM-1, which was characterized as persistent reaction to frustration through temper tantrums and destructive behaviors. This was the first disorder of impulsive-aggressive in the DSM books. In the DSM-2, passive-aggressive personality aggressive type was upgraded to explosive personality. This was characterized by aggressive individuals who were over-responsive to environmental pressure and had intermittently violent behaviors. The DSM-3 criteria for intermittent explosive disorder was poorly operationalized, and they were very problematic, so people who should have been diagnosed with IED were not. IED was originally thought to be a rare disorder. However, during my research, I found that they believe the prevalence rates of individuals within the US is actually as high as 6%, not the 2.7% that was seen in the DSM-5. Other studies have also found that the prevalence rate of IED in the general world population is between 2 and 5%. For assessment of IED is not well understood, even though it is among the more common problematic disorders. However, diagnosis is done through structured clinical interviews, which focus on the form, function, and frequency of aggressive behavior. This can be aided by trait measures of aggression and anger, such as the Overt Aggression Scale Modified, which is a valid and reliable measure of the state, such as the week-to-week aggression. Differential diagnosis may be disruptive mood dysregulation disorder, which is characterized by persistently negative mood states between impulsive, aggressive outbursts, beginning before the age of 10, but this disorder cannot be diagnosed after the age of 18. These disorders are very, very similar. However, IED can be diagnosed after the age of 18. Antisocial personality disorder and borderline personality disorder both have the level of impulsive aggression. The level of impulsive aggression is lower than that of IED. And that outbursts in ADHD are due to impulses, they're not random. Conduct disorder outbursts are characterized by proactive and predatory outbursts, which is different than IED. And oppositional defiant disorder is characterized by temper tantrums and verbal arguments, whereas IED outbursts are in response to a broader array of provocation and include physical assault. So although these disorders are very similar, when you get down to the nitty-gritty details of IED, you can kind of differentiate between the diagnoses. Treatment of IED includes pharmacotherapy to modulate the level of emotional arousal. So this can be done through selective serotonin reuptake inhibitors, which increase serotonin as neurotransmitters. And the highly studied SSRI in the research I found was Prozac, and this was seen to significantly improve behaviors. Other drugs include mood stabilizers such as lithium and anticonvulsants, antipsychotics, beta blockers. However, research on drug treatment is very limited in IED, and more research is needed to know what is the best treatment for IED. The behavioral therapy that is used to treat IED is cognitive behavioral therapy, which combines cognitive restructuring, coping skills training, and relaxation training. School-based violence prevention programs may also help. And a combination of therapy and medication is also a possible treatment and can be very helpful. So during my research, I found that there are also surgical treatments for the treatment of aggression, which is done through the stimulation of the structures involved in modulating aggression within the limbic system. These systems include the amygdala because of its well-defined involvement in emotions and aggression, and the hypothalamus, which regulates body function. So for the case study, I'll just read this to you. Eric is a 21-year-old white male from the United States. He has a short temper and is very short with people who think differently than he does. At times, Eric has been verbally demeaning of people who think differently instead of allowing them their own opinions. Eric is constantly fidgeting and adjusting his clothes. In the past year, Eric's explosive behavior has caused him to destroy other individuals' properties at least 3 times. On one occasion, Eric destroyed a friend's table while in the process of trying to fix it. Another occasion saw Eric destroying property at a mall. Eric has also lost jobs in the past after becoming physically and verbally aggressive with customers. Eric also has more frequent but less severe outbursts when he cannot control his aggression. Eric will sporadically lash out verbally towards his family and friends, and even once screamed at his mother, "Shut the bad word up," after she asked him a simple question. Eric's family have stated that he will go on tirades, have temper tantrums, or get into verbal arguments with them multiple times a week, although these episodes do not typically last longer than 20 to 30 minutes. So Eric may be diagnosed with intermittent explosive disorder. He portrays symptoms of an inability to control his impulses that are represented by frequent outbursts, which is criterion A, and he has weekly outbursts that are frequent and non-provoked verbal outbursts towards individuals that less than 30 minutes, which is criterion A1. And over the last year, Eric has had 3 or more destructive outbursts, which saw destruction of property, or he has become physically aggressive towards somebody, which is criterion A2. Eric's aggressiveness is also out of proportion to the provocation or the precipitating stressor, which is criterion B, and are not premeditated or committed to achieve a goal, which is criterion C. Eric has suffered from marked distress and impairment in occupational and interpersonal functioning due to his outbursts, which is criterion D, and Eric is above the developmental age of 6 years old, which is criterion E. Eric's outbursts are not better explained by another mental disorder and are not due to substance use, which is criterion F. So you can see here that Eric meets all of the diagnostic criteria for intermittent explosive disorder. These are my references. Thank you so much for listening.